All right, so we left off with orthodontic records and treatment planning from our last discussion. So then we're going to move on to the clinical examination is used to document, measure, and analyze facial proportions of the patient. We use this examination to evaluate oral health, to determine if there's any treatment that needs to be completed before the fixed appliances are placed, and to also evaluate jaw and occlusal function. The records are required in the form of photographs, radiographs, and diagnostic models. An orthodontic record cannot be complete if one of these items is missing from the entire piece of diagnostic information. Photographs are useful as an aid to identify your patient, to plan the treatment, to present the case, and to have case documentation of how the patient is progressing throughout the treatment, as well as patient education. The photographs capture the shape, color, texture, and characteristics of the intraoral as well as extraoral structures. There are two standard extraoral photos that are taken: the frontal view of the patient's entire face, and then the view from the profile. So they'll stand to the side. And there are three standard intraoral photos that are also routinely taken, and they're the full direct view of the teeth and occlusion, basically with the lips and cheeks retracted, and then maxillary occlusal view and the right buccal view. So here we have the extraoral photos. So the picture of the young lady smiling is the frontal, and the one along the side is the profile picture. Here are the standard intraoral photos, and we have A, looking at the occlusal, or the teeth from the front, and looking at the relationships of the maxillary mandibular teeth. We have the maxillary shot using a mirror in photograph B, and photograph C is looking at the right buccal occlusal relationship. So this patient is in the Engels classification of class 1 occlusion. You can see that maxillary mesial buccal cusp resting into the buccal groove of the mandibular first molar. This photograph is also taken with a mirror. When I was working in orthodontics, we also took a photograph of the mandibular arch as well as the left buccal occlusal relationship, because we thought that would be a more complete series of photos to look at the lower teeth and the upper teeth and both right and left sides on the buccal. Radiographs are very important. A panoramic is one that you're very familiar with. This is used to view the eruption process of primary teeth if they are still present, as well as if permanent teeth, if they are missing, to evaluate the amount of space available for the eruption process if the patient is still waiting for some teeth to come into the oral cavity. A cephalometric radiograph is something that you might not be super familiar with, but this is an extraoral radiograph as well, making it possible to evaluate the anatomic basis for malocclusion, as well as looking at the skull as a whole, the bones of the skull, and soft tissue. To do a cephalometric analysis, this is not completed on the radiograph itself, but instead is performed as a tracing or as a computerized drawing that emphasizes the relationships among selected points on the radiograph. The orthodontist uses landmarks that are present on the cephalometric radiograph, which are represented as a series of points, making it possible to compute a means of mathematical descriptions and measurements of the status of the patient's skull. The orthodontist can then recognize growth patterns that reveal the type of treatment that should be provided to their patient. So here's a look. Photograph B shows a radiograph, which is a cephalometric view of a patient. Photograph B shows those different little points of interest for our patient. And then photograph C shows the relationships between those points of interest and how many degrees or millimeters between those points of interest there are to indicate if the patient is still growing or if there is movement that is possible between those areas. Diagnostic casts are used for the diagnosis and case presentation of the orthodontic patient, as well as in space analysis of the dentition. The orthodontic diagnostic cast is commonly made from plaster and is constructed in a precise and finished manner. So these are the casts that you made in dental materials, and the videos that you watched for the dental materials lab is how these diagnostic casts are made for orthodontic case presentation. The orthodontist is going to review the information gathered and developed from the radiographs, the photographs, and the diagnostic casts, and then develop a treatment plan and cost estimate for the patient in preparation for the case presentation. At the case presentation visit, the orthodontist will use the photographs, radiographs, cephalometric tracing, diagnostic models, and any other type of aid to present the diagnosis and treatment plan to both the patient and their guardian if that is necessary. They will also then begin to make financial arrangements, which is most frequently divided into payment plans because there are several years sometimes of this treatment. We, as a dental practice, can't expect the patient to pay thousands of dollars in the first time unless that is something they're financially able to do. So our next topic is going to deal on instruments and the treatment plan, so you can look at these objectives once again. And these, and some of the specialized instruments and accessories that are used for ortho are used just in the orthodontic offices. So the orthodontic scaler is one which is used to place brackets, to also remove elastomeric rings and remove excess cement or bonding material during the banding and bracketing procedure. A ligature director is used to guide the elastic or wire ligature tie around the bracket and to also tuck the twisted and cut ligature tie underneath the arch wire. Here are some pictures of these. All of these instruments are going to be in your Modern Dental Assisting book, so please take a closer look at these. The band plugger is used to help seat a molar band for a fixed appliance, and a bite stick is used to help seat a molar band for a fixed appliance as well. So these are similar instruments. They're used for the same thing. They look a little bit different. The bracket placement tweezers is used to carry and place the bonded bracket onto the tooth surface. And at the top is that band plugger, the bite stick is in the middle, and the bracket placement tweezers is on the bottom. Some different pliers and accessories. The bird beak pliers are used to form and bend wires. The Weingart utility pliers is used in placing arch wire, and the contouring pliers is used to fitting bands so that there's no gaps around the tooth when the band is fit. A three-prong pliers has just that. It has 3 prongs, and these are used to close and adjust clasps. A posterior band remover pliers is used to, guess what, remove bands. A wire bending pliers, again, guess, this is a crazy name for it, is used to hold, bend, and adjust arch wires to create movement of the teeth. The pin and ligature cutter cuts the ligature wire for removal, and the ligature tying pliers is used for ease in ligating the band or the bracket to the wire. A Howell pliers allows for placement and removal of and the making of adjustment bends in the arch wire. Again, there are pictures of all of these pliers in your textbook. Please take a look. And they begin on page 1014, have all of the photos of these and get to know them and what they do. For orthodontic treatment, this refers to the use of fixed or removable appliances in a combination of both types of mechanically of these removable and fixed to mechanically move the jaw or the teeth. Fixed appliances refer to often as braces are a combination of bands, brackets, and auxiliaries that can be used to move a tooth in 6 directions: mesially, distally, lingually, facially, apically, and also occlusally. When we look at the sequence of appointments to place our fixed appliances, so when a patient goes in to have their braces placed, we first need to see them a day or two before the actual bonding appointment to place separators. If the patient is having bands placed, they need to have separators to move the teeth apart slightly so that those bands can be placed on the molars. After a certain number of days have passed, then we can cement the molar bands, bond the brackets, insert the arch wire and tie it with a ligature or elastomeric ties. Then they come back every couple weeks or every month for adjustments and checking to make sure the brackets are still bonded to the teeth, remove the appliance when the treatment plan is over, and finally place the retention. Separators are used to separate the teeth before fitting and placement of the molar bands. We can do these with steel separating springs or elastomeric separators. There are little checkoffs at the end of your textbook. So read the steps for placing and removing a steel separating spring and placing and removing an elastomeric ring separator on page 1023 to 1025 in your Modern Dental Assisting textbook. Orthodontic bands are pre-formed stainless steel bands that are fitted and cemented to molar teeth. They typically have little buttons or tubes and cleats that are attached for the arch wire and power products to attach themselves. The bands are then fitted to the molars, and then we cement them with usually a glass ionomer or polycarboxylate cement. The cementation of orthodontic bands is done by the dentist or the orthodontist. Here's a look at those orthodontic bands. The two on the left are plain, they don't have any auxiliaries. The others, the top right has a lingual little cleat, those little two prongs, and then they have buccal tubes and a place-to-place headgear. And the bottom right just has a little cleat to attach a rubber band. Here is another procedure that you need to be familiar with, procedure 60.3, again in your Modern Dental Assisting book on 1025 to 26, to be familiar with assisting with the fitting and cementation of orthodontic bands. To bond the brackets, on the bonded bracket, the arch wire is placed horizontally through the wings of the bracket and then ligated in place. This stabilization initiates tooth movement by allowing the forces from the arch wire to be transmitted then to the tooth. Here is a look at the bracket that is bonded to the tooth. So we have, here are the little wings. Here is the slot that the arch wire is going to pass through. And these little wings is where that elastomeric tie or the ligature tie is going to secure the arch wire to the bracket and provide the force of the movement. So here we have someone that has brackets and some different colored ligature ties. We have an auxiliary hook. If the patient was wearing rubber bands, we would have that hooking onto that little hook here. This tooth also has a hook on it. We have the arch wire passing through here. We have the slot where the arch wire is able to rest. And then this blue and the green on the other brackets is the elastomeric tie. All brackets, when they come out of the box, have these little orientation dots. So these two teeth are bicuspids. So they are, this bicuspid has a hook. This bicuspid does not, so that is one way to kind of differentiate both of those. And then the cuspid has this blue dot on it, so you can kind of tell from the way that these brackets look that if you spilled the bucket of brackets, you could kind of put them back together. This is the molar bracket, and it has an auxiliary hook here as well, and it also has a little slot in it for the arch wire to be able to travel through. That's called the buccal tube for that molar bracket.